Danae, I'm not able to hear you. You might be on mute.
Oh, I was just talking away. So I apologize, guys. We're going to go ahead and get started. We have a lot of information to go over today. My name is Danae Gailey. I am a care manager here with BDDS. I'll be presenting the first half, and then halfway through the training, we're going to jump over to Andrea Hatch. She is also a care manager here with BDDS, and she'll cover some of the costing and some additional forms. Just a real quick caveat, I do have some dental work going on, so I kind of look a little funny, but it also is impacting my speech a little. So if I talk a little funny and if you're having trouble understanding, please let us know, and we will do our best to get you the information you need. We are in part 2 of the KW implementation training for service coordinators. So today we're going to go over the ISP, the new plans, costing sheets, questionnaires, and some quick housekeeping items is we are going to pause periodically throughout training for questions. Make sure you get those questions into the chat box. If you do have a Q&A feature, I don't think you do at this point, but if you do, if you could please exit it so we are able to capture all of those questions accurately and get them addressed. You can also raise your hand and ask those questions verbally, and then when asking your questions in the chat box, if you could address those to everyone or all panelists only, it's also really hard to capture them if they just go to the host or the presenter. So this training is being recorded. A copy of it will be made available on the My Choice Matters website, so you can reference back to it at any time you need. The slides and the drafts documents were sent out, I think, on May 4th. So if you had a chance to review those beforehand, great. If for some reason you weren't on the list or you didn't receive them, they also are posted on the My Choice Matters website. All right, so the basic overview of what we're going to cover today are the individual service plans, service questionnaires, the costing pages, implementation plans, status reviews, addendums, certified family home alone time changes, and some appeal basics. So we're going to jump into some general review and addendum guidelines. So as care managers, when we review the plan and the supporting documentation, there are certain things that we are looking for so we can approve. And so we approve when all the following conditions are met. So all the documentation is submitted and completed accurately. The participant qualifies for all the services on the plans and they are within any established limits. The services on the plan address participant needs and service preferences. The plan maintains participant rights and addresses risks with the least restrictive methods. And then the plan is either within the advisory budget, and if you remember from part 1, the advisory budget is going to be that new budget that you'll see from Liberty when they do the switch over to the CIS-A, so that will have the different buckets of money, or within the assigned budget and meet all the prior authorization requirements. That assigned budget is going to be known as the, well, may or may not be the ARP budget, but the ARP budget is the highest budget they've had since April 1st, 2021, very similar to the KW budget we see now. So whatever one is the highest, whether the advisory budget or the ARP budget, that now becomes the assigned budget. Or if it exceeds the assigned budget, so if it exceeds both budgets there, we are looking at a budget modification request with documentation that establishes those services are needed for to address health and safety needs is submitted. That's very similar to the health and safety risk exception reviews we do now. And so if there are any issues that are with the plan, the care managers are going to work with plan developers to resolve those. And if we can't meet a resolution, that's when the plan would be denied or a partial denial will be sent, and the participant will have appeal rights. So we're going to go more in detail those prior authorization requirements. This is directly from IDAPA. The purpose of adult developmental disability services prior authorization is to assure the provision of the right care in the right place at the right price and with the right outcomes in order to enhance health and safety and to promote participants' rights, self-determination, and independence. Prior authorization involves the assessment of the need for services, development of a budget, development of a plan of services, prior approval of services, and the quality improvement program. Services are reimbursable. They are identified on the authorized plan of service and are consistent with the purpose and rule for prior authorization, as well as rules for the specific service. So just a quick note here, even if the services are in budget, care managers are looking to make sure that all the services within budget still do meet the prior authorization requirements. We're going to jump into the submission timeline. So initial plans are due 30 days before the requested start date. Annual, prorated, and mid-year plans are due 45 days prior to the requested start date. The big difference here is that the mid-year plans, so those are kind of a new concept, and they also will be due 45 days prior to that start date. In emergency situations where the participant needs services now and cannot wait the 45 days, there will be extenuating circumstances where you can reach out to that care manager and work with them to get an expedited start date on those. We also will still have the option to do an extension of the previous plan if needed. So late plan notices will be sent out if the plan's not received within 1 week after the due date. The due date's listed on the eligibility notice you get from Liberty. There's a couple exceptions to that. So if the plan is late due to eligibility delays, we would not send a late plan notice. Or if the plan developer has reached out to the care manager beforehand and they've worked out a reason why that plan is coming in late. So the next section goes over incomplete plans. I just want to make a note here that during implementation and while we're transitioning to the new budget tool, the new service array, the new plans, we are not going to be sending out incomplete plan notices. But care managers have been asked to CC QA on any corrections emails. So if we're sending something back to you asking for corrections, you will see that the QA is CC'd on those. That's not for any plan of corrections or anything of that sort. That's simply for the department as a whole to have a place to track those, to identify any gaps in the process, trends, training needs, those types of things. So I'm not going to go over every single one of these bullets in detail after the implementation happens, when you would receive an incomplete plan or addendum notice. This will be a resource available to you on that My Choice Matters website if you want to review it more in detail. A quick takeaway here, though, is there are some fields on the plan that repeat onto every single page. So it's really important, like when you're doing the header, and we'll get into an example of what that looks like, that we get the information in there correctly the first time, because if it's incorrect on one page, it's going to be incorrect on every single page. So before we jump into the actual plan, the plan forms, are there any questions that anybody's seeing or any hands raised? Okay, I don't think I'm seeing anything
today.
Perfect. All right, so the first part of the plan, the new plan is set up into about 4 different categories, and then there's some questionnaires. So the first category in the plan is the personal and plan developer information. And the way these slides are set up is there's lots of instructions on one page, and then there's the example on the next slide. We're going to do a lot of jumping straight to the example, so you'll have a visual aid to look at as I'm explaining it. But like I said, these slides will be a resource, so you can pull that up at any point. We will have a new external manual that has ISP instructions in it that gives more details on how to navigate the form and what needs to go in each field as well. So this first section is the personal and plan developer information. This is basic demographic information for the participant and the plan developer. We are asking that the participant name, Medicaid ID matches exactly what's on that Medicaid card, because we want to make sure that we are prior authorizing the correct person. If there is a guardian, this is where their information would go. We will be checking if there is a guardian listed. We will be checking to make sure we have guardianship documents on file. If not, we would be requesting those. And so this is just filling out that basic demographic information. If you take note here that where I was talking about the header, the stuff that repeats onto every page, that's that first little part that says participant name, Medicaid ID, plan start and end date. The next section of the plan is the person-centered planning section. So the first subcategory of that is the participant strengths, goals, and preferences. So every part of this person-centered planning section, we're asking that these are discussed during the PCP meeting. They reflect the maximum possible involvement by the participant in that process. The first question are, what are the participant's strengths? So we ask that you list the participant's strengths that are identified by the participant, the team, yourself, and all those strengths get listed here. So in this example, good listener, easily makes friends, etc. The next question is, what services are important to the participant? And we're asking you include preferred providers and delivery preferences. A quick note here is that if it's important, or if something is important to the participant and it's not something they are currently accessing, it would still need to be listed here. So it's not necessarily what services they're accessing, it's what's important to them. And so certified, for example, in this example, we have certified family home with Mary Jones. So we're saying, you know, what's the service and who's the preferred provider, developmental therapy and community hub, and they have the preferred provider as ABCDDA, and they would like to have 2 days in center, 3 days community. So they're identifying the preferred providers and preferences there. The next question is, what did the participant identify as their personal goals and their desired outcomes? So this is a question we're asking, you ask in that PCP meeting to the participant themselves, and then list their personal goals here. The personal goals can be something like they want to find a job. It can be something like they want to be Superman. We are really looking for that participant involvement here. And to note, though, we do understand there are situations where the participant involvement is not possible. For example, they refuse to provide any feedback, or their disability makes it to where they are not able to provide that feedback because maybe they're nonverbal. Or if that is the case, in this section, we would like you to make the note why the question, why they were not able to give their input here. The next one is, what activities will assist them in achieving their goals and outcomes, and who's going to help them complete these activities? So same discussion, discuss that with the PCP team, that participant, and what can we do to help them with those personal goals, and who's going to help them? So in this example, John wants to find a job this year, and the service coordinator is going to link John to IDBR to explore employment options. John also wants to attend a Boise State football game. So we have the guardian and payee help with budgeting, determining how much money he needs to set aside each month to meet that goal, and developmental therapy is going to work on some money management goals. The next one is, where do the participants choose to live and or receive services? This also should reflect their choice, not necessarily their current situation. So maybe maybe John is currently residing in a certified family home, but would like to reside in supported living, and somebody's going to help him do that. We want to see his chosen living situation here. So is everybody hearing me okay? Yeah, okay. All right. So we want to see his chosen living situation in this, and then the next question is what service option settings were considered. So John is considered living with his guardian, but he determined he has a better relationship now that he lives in a different certified family home. Hold on, give me just a second. Okay, I apologize. We're having some technical difficulties. Like I said, I have some medical issues. I got a scratch in my throat. We're just trying to make it through today. So the alternative setting options that were considered would need to be listing there. So like in this example, he thought about living with his guardian, but determined that that wasn't the best fit for him, but he does want to explore some supported living. All right, so the next part of the person-centered planning is the risk factor setting. So this should involve as much possible involvement as well. And so this first section addresses a couple different categories of risk. The first one is the home and community-based service qualities from IDAPA. So that rule says that HCBS services have to exhibit the following required qualities. And I am struggling. Andrew, do you want to try to present for a second so I can get myself in a spot? I apologize.
Sure thing. All right. So risk factors. So home and community-based settings are required to follow, to exhibit the following qualities. Integration and access where services and supports are provided. A selection of setting is based on participant needs and preferences. Ensuring that participant rights of privacy, dignity, respect, and freedom from coercion and unauthorized restraint are honored. Autonomy and independence of participant choices is optimized rather than regimented. And then choices about services and supports are provided in the setting and are promoted. So any risks that are associated with those setting qualities that we just talked about, and in addition to that, any general risks to the participant around them need to be listed in this next section of the plan. And so we'll go ahead and skip to the example here. And so for the risk factor section, you'll see that there's two sections. So in this first column on the left, it will ask what risk factors are there to the participant or to people around them. And so each risk that is identified by the team should be identified in this section. And then on the right-hand side, there's a section that asks what measures are in place to minimize this risk, backup plans and strategies as needed. So we've got a couple of examples here, and we won't go through all of them, but one example here is exploitation by others in the community. And so then that example is that DT will work on safety skill goals in the community. Community habilitation will provide support while interacting in the community. Certified family home will work on alone time scenarios in the home, and alone time will not take place in the community without either paid or natural supports. So we've got several examples here, and then in the external manual that you will have access to, there will also be instructions so that if you need more than the number of fields for this section, you can continue to add additional fields for every risk that is identified. The next section of the plan is the participant rights section. And so again, this is another section that should be discussed during the PCP meeting, and it should reflect the maximum possible involvement by the participant in that person-centered planning process. And so for participant rights, provider-owned or controlled settings, and that includes certified family homes that provide services to HCBS participants, must provide support for all of the following rights that are listed here. So we have a written agreement, so like a lease or like the residential agreement for certified family homes, a right to privacy, a right to choose decor and furniture, a right to control their own schedules and their activities, access to food, visitors, which means anyone at any time, and that their living situation is physically accessible. So if there are any exceptions to any of those setting requirements that are outlined up above, then they need to be addressed in this section of the ISP. So we'll go ahead and switch over to the example so you can see what this is going to look like. So for the participant rights, it's going to ask, are any of the participants' rights being restricted, and asks yes or no. If that answer is no, and there are no restrictions to any of those rights, then you can go ahead and skip past this to the next section. If there are rights that are being restricted, it should be marked yes, and then the question should be answered below. And so we'll just go through each one of those, and we've gotten an example here. And there will be a lot more examples and additional instruction in the manual as well, once that's available on our external website. So the first question that it's going to ask is describe the rights being restricted and why. What assessed needs are being addressed by the restriction? So in our example, this first part is going to address what's being restricted. So it says, John needs to get approval from the certified family home provider to have visitors after 10 p.m. or before 8 a.m. John has made unsafe decisions in the past when inviting strangers from the internet into the home, potentially putting himself, his providers, and roommates at risk. And so then this last part, John needs assistance to make safe decisions involving members of the community. So we're identifying what is being restricted, which is that visitation. And then the need is that he needs help to make those safe decisions with community members. The next question asks, provide a clear description of the intervention that's being used, assuring the support will cause no harm to the participant. So for this example, we're wanting to show exactly the details of this intervention, and then by detailing this out, we're assuring that there's no harm to the participant by using this restriction. So this example, the certified family home will discuss with John any potential visitors during the hours of 10 p.m. to 8 a.m., which are sleeping hours, to decide if the visitor is a stranger who presents a potential risk, or is a visitor that the certified family home and John both agree is not a threat to anyone in the home. If the visitor presents a potential risk, the certified family home provider will not allow the visitor to enter the home during those hours, and will redirect John to have the visit during waking hours when someone is awake and available to monitor and address any potential issues. So by detailing out how that restriction is going to work, we're just assuring that there's no harm to the participant there. Then the next question is list less intrusive methods previously implemented that were unsuccessful in addressing participant needs. So for this question, we're required to identify that there were previous methods that were implemented and that were attempted before jumping into using a restriction here. And so for this example, there were discussions with John to make safe choices regarding visitors, but he continues to invite strangers from the internet to visit the home during sleeping hours. So we're just identifying what things have been tried in the past. The next question, how will the provider regularly collect data and measure the ongoing effectiveness of the restriction? And so that is a requirement of those HCBS rules. And so in this example, the certified family home will document any occurrences where John has invited a visitor to the home during sleeping hours, and if the visitor was determined to be a potential threat or a safe visitor. So they're just identifying how they're going to collect that data. And then the last question, how often will the PCP team conduct reviews to determine if the restriction is still necessary, if a transition plan can be developed, or if the restriction can be terminated? So in this section, we're just looking for an interval where this is going to be reviewed to see if the restriction is still needed. And so in this example, we just have every 6 months. Let's go ahead and move on to the next section, the supports and services. And so I'm going to go ahead and skip over to the examples on these ones as well. So the first part of the supports and services is specifically towards service coordination. And so these first sections, we ask for the frequency of contact, the mode of contact. These are all modes of contact with the participant and their team. And so it's not necessarily only for those face-to-faces. Those face-to-faces have not changed, but there are other methods where they may communicate at other times. The person or entities to contact would be listed. And then there is a question, has the service coordinator ensured that there is no duplication of services? And so this question, for us to be able to approve the plan, it does need to be marked yes, because that is a responsibility to ensure that there has been no duplication of services. If a plan were to come in and this were to be marked no, this is something that we would send back to the plan developer to ask them to ensure that there has been no duplication of services. The next part of this section asks, has the service coordinator received all of the applicable provider status reviews? We have a question very similar to this on our current plan. Respond to that yes or no. If the answer is a no, provide an explanation as to, maybe what hasn't been received, or if you know why that hasn't been received. The next question asks, what participant-specific goals will be addressed during the plan year? And so this one, we don't want just a list of generic, IDAPA requirements. This is where we want those participant-specific goals that the service coordinator is going to be addressing. So in this example, we have that they are going to link them to IDVR and that they're going to link them to peer supports, because those are two services that they identified an interest in. And then this last question, what should the participant, families, and provider do in an emergency when the service coordinator is not available? So this is the section where you put in that kind of emergency information for who they can contact when the service coordinator is not available. So in this example, we have that they can contact 911 for a medical emergency. They've got the contact information for the guardian there, and that the service coordinator will follow up with them, with the participant, guardian, and then any of the relevant providers that next business day to discuss any other further needs that stem from that emergency. So then this next section, and again, we're going to go ahead and skip straight to the example on the supports and services, is we have the rest of the DD paid services. So this top section for DD paid services, these are services that are billable to the DD waiver. These are ones that are going to be on the cost sheet that we go over later. And there's just two sections for this. Under service, you'll put the name of the service. So in these examples, we have developmental therapy, community habilitation, and certified family home for those services. And then on the right-hand side, we have a column for the provider, and that's where you'll put the name of the provider. Then the next section of this is for non-DD paid services. So those are those services that are funded through another source. So we've got a couple of examples here. We've got occupational therapy, we have their primary care physician, and then it looks like they've got some medication management. Are those services that are provided by another funding source? Some other examples here, just because I think we've had some questions on this in the past. You know, if they're receiving a service, maybe through A&D waiver, like they're receiving, maybe their certified family home is through A&D waiver, or maybe their adult day health is through A&D waiver. Those will go in the non-DD paid services section. We still want to know that they're receiving those services, but they're not paid through the DD waiver program. So you'll have the name of the service in that left-hand column. The middle column will have the name of the provider that will be providing that service. And then on the right-hand side, the frequency, you'll just put on how often they will be receiving that service. And then this last section is for natural or unpaid supports. So this is where you'll list any supports that the participant has that are non-paid or natural supports. So in this example, we have a guardian, we have a church, and then we also have a girlfriend that are listed. Under provider, you just put whoever it is that's providing that support. So we have those different examples here. And then the frequency, again, in the right-hand column for how often they'll be providing that service or that support. And we do have some situations where we do have occasionally participants who really don't have any natural supports. We don't have a lot of that, but if we do have someone who really legitimately does not have any natural support, then we wouldn't expect something there. But care managers will be looking, and if we're identifying in the MSDA that maybe they do attend church, or you know, there's family members or friends or other people that do provide that natural support, we would want to see them listed in this section. All right, and then Danae, are you back?
I think so. I mean,
okay, I'll let you take over on
give
the
it a go.
Page.
Okay. So the last page of the main ISP is the signature page. Andrew, if you want to jump to an example of that. This first section here is the informed consent section. So this section must be signed by the participant and the guardian, if applicable. So they're signing that the participant and the guardian directed the development of the plan, the participant made choices on services and providers, the plan meets needs, addresses health and safety, and changes will not be made without the participant and guardian's consent. So that's what that first signature indicates. The second signature here is the informed choice. So this must be signed by the participant and guardian if it is a DD waiver plan. It is not a requirement for DD state plan. This is very similar to the initials that we get today on our current ISPs. So the informed choice, when they sign here, they're indicating that they're choosing to receive DD waiver services instead of care in an ICFID facility, and they can choose that ICFID admission at any time. The last section is the plan developer section. So this is where you guys would sign. And by signing it, you are signing that you provided information and supports to maximize the participant's ability to make informed choices regarding services and providers. The plan meets participants' needs, addresses health and safety, and reflects participant choices. And the plan developer will monitor the plan, review services to ensure they're delivered according to the plan in accordance with HCBS setting requirements. So that is the main plan that you would have to submit for every single participant. And then the next section, we're going to go over questionnaires for particular services. So I think it's a good stopping point for questions. So feel free to put any questions in the chat, and then let's see.
There is a question in the chat. What are the requirements to have a mid-year plan? Does the participant need to have a change of condition and have a reassessment with Liberty?
I can answer that. So mid-year plans are relevant whenever a participant is in a situation where they need to change either their level or their service mix. So the situations that could occur that could require a new plan to be submitted in the middle of the year would be a change in condition. So a need so significant that they needed to receive a new assessment to accurately reflect their support needs. A change in service mix. So a situation where a participant decided to switch the way they were currently getting services and move to a different way of getting services. So someone who was residing in a certified family home and then elected in the middle of the year to move to a supported living situation, because that would be a service mix change. Or a situation where somebody declined to go through the verification review process at the point of their assessment, but later identified that they did want to go ahead and go through that process. And as a result of going through verification in the middle of the year, were assigned to levels M or B. So a mid-year plan only comes into play when someone's budget is going to change, and they are then going to get a new budget notice, which would be the indication of a need for a mid-year plan versus an addendum per the old process.
Okay, and we do have a second question. Page 21, does service coordination and plan development go in the DD paid services section?
So she's talking about the services and supports where we have the DD paid services, non-DD paid services, and natural unpaid services. And yes, service coordination would go in that DD paid services. We just need to make sure that anything that goes in there matches what's on that costing sheet. So those are the services that you're requesting be paid through their DD budget.
Okay, and I'm not seeing any other questions at this time. I do want to remind everybody that if you want to speak your question rather than put it in the chat, you would simply need to raise your hand and then we will unmute you. Just a reminder, it seems like everybody's doing it, but make sure that the questions go to either all panelists or everyone. Otherwise, we're not able to capture them. Okay. Perfect. So we're going to jump into questionnaires. So if there's a list of services that if they are being requested on the plan, that an additional form will need to be submitted. We're calling these additional forms questionnaires. So if the participant wishes to access residential habilitation, certified family home, or supported living, there's a particular questionnaire for that. Developmental therapy, adult day health, pre-vocational services, career planning, supported employment, nursing services, behavioral consultation, crisis management, and community habilitation. So anytime that you are adding one of these services or one of these services are on the plan, the questionnaire will need to be submitted. And so all the questionnaires, all of them have some basic same information. They have the header information. So that includes the participant name, Medicaid ID, plan start. They have the provider name. They have the representative name, and they will require that provider signature. So we're going to jump into what those questionnaires look like. The first one we're going to get into is the Certified Family Home Questionnaire. Andrea, do you want to jump to that? So the Certified Family Home Questionnaire, like you see that header there. That's going to appear on all of them. The provider name, it does specify as it appears in Gainwell. We are asking that that provider name matches what's in Gainwell, which is the billing system. So we ensure that we are authorizing that correct provider. The Certified Family Home specific stuff, we have alone time on here. So does that participant wish to access alone time? If the answer to that question is no, you can skip down to the goal section. If the answer to that question is yes, there's some follow-up questions here. So we're asking the requested weekly amount of alone time. So in this example, that's 14 hours. And then we are asking the maximum increment of time alone. So this participant, in this example, can be alone for 14 hours throughout the week, but only 2 hours at a time. So it doesn't appear that they would be safe for 14 hours in one whole chunk. So that's a distinguishment between those two. And then we're asking when and where the alone time would occur. So this one's at home during daytime hours. And if the PCP team agrees that the participant can follow an alone time safety plan, yes or no there. If that is indicated no, the care manager is probably going to reach out and ask some questions as to why that wouldn't be safe and why it's still being requested, and try to get some more information there. Then we jump into the goals section, and so we have the informal goals. So things they're not collecting data or have objectives on, but have agreed to work on with that participant. It's on the left-hand side. And then we have formal goals. And so things that for a certified family home, this would be that RISE is assisting with the implementation plans and collecting data on those. So there is one situation where certified family home, we may see a to be determined here. It would be in the case that this is an initial certified family home, the initial time you're adding that, and it hasn't gone to RISE yet. So that is what the certified family home questionnaire looks like. We'll jump into the supported living questionnaire. So same basic information at the top, and then it does ask what supported living option has the participant chose. So there are the 5 different per diem levels, or you can choose the per unit rates. If you choose a per diem level, then we don't need the per unit questions answered, but if you do choose a per unit, it does then go into asking the average requested weekly group hours, the average requested weekly individual hours, and the average requested weekly 2-on-1 hours. And so we're asking the provider and the plan developer to estimate what the average amount of those hours is going to look like and list that on the plan. Informal goals on the left-hand side, formal goals on the right-hand side, and then we've got the provider authorized name and signature. The next question is for developmental therapy. So the first question on here, has developmental therapy been referred by a physician? If this is marked no, we are unable to approve developmental therapy on the plan. It is a requirement that developmental therapy be referred by a physician. So this is, it's typically we see this in a history physical. You can get this from a medical care form, whatever you need, but we have to have the DDA signing that they do have a referral, and we're asking service coordinators to verify that to the best of their ability. And then the next question down is how many hours of center developmental therapy will they receive, and how many hours of community. So just the requested amount of hours in each setting. And then the left-hand side, informal goals, right-hand side, formal goals. All right. The next one is adult day health. So adult day health is a pretty basic one. Just how many hours of adult day health will they receive each week? And then because adult day health is not required to create formal goals, we just ask that you leave the formal goals section blank and you list the informal goals. So what they're going to be doing in the adult day health setting. The next one is pre-vocational services. So pre-vocational services, we're asking how many hours of individual per week and then how many hours of group per week. And so we're just asking for those to be distinguished here. And then that second question down is, have they previously accessed pre-vocational services? If you mark yes, then we would like to know for how many hours, because there is a limit of 520 hours total to pre-vocational services. So you would need to be looking at previous plans to see if this is something that they've accessed in the past and calculate that out there. And then have you list the informal goals and formal goals on the right. The next one is for career planning. It's very
kind of straight to the point, how many hours of career planning will they receive each week? And then, so just asking that be listed there, and then informal goals on the left and formal goals on the right. Supported employment, so also just the weekly amount of hours that they're requesting, we have that listed there. And then, is the participant performing competitive work in an integrated work setting? This is also a question that if this is marked no, we would not be able to approve supported employment on the plan. So supported employment is only for competitive work in an integrated work setting. So we're asking that the plan developer verify that and that the CSE provider signs off on that. And then we have informal goals on the left, formal goals on the right. Next one is nursing services. So very similar to developmental therapy, we have the nursing services being referred by a physician. This is a requirement to access nursing services that there is a referral by a physician. So you can look for that in a medical care form. That could be a history and physical. That can be a direct referral. So we're asking that the nursing agencies sign off that they have a referral, and we're asking service coordinators to verify that to the best of their ability. The units and frequency question here, so it breaks it down by nursing oversight by RN, by LPN, skilled nursing by RN and by LPN, and we're just asking you to list how many units and how often that's going to happen. So like in this situation, that person has one nursing oversight unit per month by an RN, and they have 24 skilled nursing by an LPN per year. So the next question is, or the next questionnaire is behavioral consultation and crisis management. So this one breaks it down to the type of professional that's providing that service. So how many hours of crisis management will be provided by an emergency intervention technician, by the QIDP clinician, or by the psychiatrist. And so break down those weekly hours by the type of professional. And then informal goals on the left, and this is not a service that requires formal goals, so those can be left blank. And I probably left that out on nursing now that I think about it. So nursing, formal goals, I left blank as well. The next one is community habilitation. So community habilitation, the frequency amounts that we're requesting here are based off the staffing ratio. So how many one-on-one per week, how much one-on-two, how much one-on-three, or how much two-on-one. So the frequency of how that will happen. And then informal goals on the left, and then those formal goals can also be blank because that's not a requirement of community habilitation. So that was a lot of information in the questionnaire, pretty quick. So let's go ahead and jump to see if we have any questions.
Hi, we do have some questions that have come in. The first, we no longer have to outline formal goals. That's the question.
Okay. And I hope that getting into the questionnaires address that, because the questionnaires do have those formal goals listed for the providers that are required to have them.
Okay. Next question. Do we have to do a mid-year plan if the additional service is not putting them over the budget?
So yes, so it depends on the particular situation. So if the service that they're requesting to access puts them into a different service mix, then yes. For example, if they are in a supported living service mix and they are now choosing to go to a certified family home, then yes, you would have to submit a service mix request. It would go to Liberty to get a new budget, and we would see it mid-year plan. But if they're just looking to increase or decrease supported living or add some discretionary services, everything falls within budget, they're not going outside of their level, then no. So I think it's very particular to each situation.
All right, thank you. Then there was a comment
Can I
coming
add,
up about,
sorry, can I add one clarification on that too? So for supported living, like if they're, like maybe their service mix is like supported living level 3 and that's what they have and they want to change and they only want to receive level 1. So since that's less service than what their service mix is, they can do that. It's if like they're wanting to change to maybe level M and B and going through verification, then it would need to be a new service mix and a new mid-year plan. But they can reduce the amount of supported living without that having to be a brand new mid-year plan. Sorry, that's all.
Perfect.
thank you. There was a comment about not being able to see everyone as an option on the chat. You may need to scroll down to the end to see everyone. And no worries if you don't see everyone, as long as you use all panelists, we will be able to capture the questions. There have been some questions that went in straight to the host. Those are difficult to keep track of and capture, so please use all panelists or everyone. Next question, let's see. There was a question about CSE, but then the inquirer said, never mind. So I think we're going to skip that question. Then the next question is, if we are unable to positively verify how many hours of pre-vocational they have received from VR, what should we do?
So this wouldn't be how many hours they've received from VR. This would be how many hours that they've billed of pre-vocational services through their DD waiver plan. So this would be going back to the previous year's plans, addendums, and seeing how many hours that they have accessed through their DD waiver for that particular pre-vocational service. If you are like questioning it or you don't know, feel free to reach out to the assigned care manager. We can always look and try to work out that number together. So I would say do it to the best of your ability, but if you're struggling, feel free to reach out to that assigned care manager and we can flip through and try to get that number, help you get to that number.
Continuing with questions about pre-vocational services, is the 520 hours for pre-vocational per plan year or lifetime?
This is in total, so per lifetime, not per plan year.
Can you define pre-vocational services as well as integrated and competitive work environment?
Alina, do you want to jump in on the pre-vocational, maybe?
Yeah, I'm happy to do so. And we do have some information about that service, which is available on part 1 of this presentation. You also are welcome to review those slides to look at that information. But the pre-vocational service is a service that is really intended to help someone get ready for competitive integrated employment. So if there are skills that someone needs to develop that are not job specific, but more general skills around employment, you know, how to get ready and get out the door on time, how to interact with your coworkers or customers, those are the kinds of skills that can be developed using the pre-vocational support. That service is intended to be time limited because it is to build some of those base skills that someone needs in order to get closer to and build the nature of the skills they need in order to be successful in employment. And if someone needs more job specific skills, that's something that can help be developed through the supported employment service. The second part of that question, I have forgotten. So if you'll get back to me, I will be sure to respond to it.
Can you define also integrated and competitive work environment?
Oh, yes. Thank you so much, Amanda. So a competitive integrated work environment is really just referring to the ability for someone to receive their job or to do their work out in the community like anyone else. So they would be receiving a competitive wage, which is a minimum of minimum wage. They would be working in an environment where some of their coworkers or other employees are people without intellectual or developmental disabilities, and are doing so out in their community. So this would be different than working, say, in like a sheltered workshop where they may be receiving something lower than minimum wage and are primarily or exclusively surrounded by peers who also have intellectual and developmental disabilities.
Okay, next question. Do you still have to submit a nursing plan if nursing services are on the plan?
Yes. Yeah, long story short, yes. We will have an external manual posted that has all the services in there. And in that external manual, once it's finalized, you'll be able to review it, and it will tell you which documentation is required for what service. So anytime in nursing is being added to a plan or via an addendum, that will be a requirement.
Thank you. The next question, what would counseling services fall under? Behavior intervention / crisis form, ? It was mentioned that the formal goals would not be necessary, but counseling has formal goals. Maybe I missed that form or we haven't gotten to it yet.
So counseling services, because they're not a DD paid services, there's not a questionnaire for them. Those would fall under, you would just put on the supports and services page under that non-DD paid services is where we're going to see those mental health services, whether that be counseling, peer support, and we are not asking for those formal counseling goals because we are asking that the service coordinators verify there's no duplication of service. So I think it's the expectation that as a service coordinator, you know those goals, and so you can ensure that they're not duplicative of any other goals that are any other services that are being requested. The behavior consultation and crisis management, that's a completely separate DD waiver service. It's something that we have today. It's just very rare, and I don't believe there's a lot of providers that provide that.
You mentioned that the department is asking the SC to verify that there is the service coordinator to verify that there is a physician's referral for DT and nursing to the best of their ability. Do they need to collect documentation on that or just ask the provider? If documentation is required, would this be something that would be looked at during a quality assurance review?
Yes, so quality assurance will be looking for the nursing referral when they're surveying the nursing service providers. So that's why we ask that, it is a requirement the service coordinators assist with getting referrals and help with that. So we're asking the service coordinators verify that to the best of their ability. But ultimately, it's looked at when they're doing the surveys for the nursing providers.
If we do a mid-year plan, does the redetermination date change?
No, so all the mid-year plans, they are going to be prorated. So the start date of the plan will change, and then the end date is going to be the same. So they will be on that same eligibility cycle with Liberty.
And then Sean, I saw you put the question back into all panelists, but we already addressed that question. Thank you for doing that. If the last question that we have right now, if we have a question regarding the ISP that our supervisor or manual is unable to answer, would you like us to CC the QA in those emails to the care manager?
I'm not sure. I mean, we can touch base with our QA team and see if that's something that they would find beneficial when they're tracking those training needs and those gaps. I definitely don't think it's going to hurt anything if you CC them, but we can take that to the table and see if that's a process we want to implement and if QA would appreciate that.
Okay, I'm not seeing any other questions at this time, and I do not see any hands raised.
I see Toby with a hand raised. Let me unmute him. Go ahead, Toby.
Sorry, I forgot to lower the hand. That's my fault.
Oh, okay.
Okay, it's lowered. Sorry.
Thanks.
All right, let's go ahead then and jump in. We still have a lot of material to go over. So let's go ahead and jump into the new costing page. So the new costing page is going to be a Microsoft Excel worksheet. It's locked to protect all of the formulas that are in that worksheet. And the formulas in that worksheet are going to calculate a lot of this information that we need for us. A few of the things it's going to do is going to calculate the plan length based on the dates that are entered in. It will calculate the budgets based on the service mix and level that is selected. It's also going to automatically prorate budgets based on those dates for any prorated or mid-year plan. So all those budgets will automatically prorate. It will calculate all of the budget categories and totals. And then it will also automatically calculate a fiscal plan summary with a bunch of information that I'll go over when we get to the example. There's a couple of other features in these worksheets. There is a drop-down menu to select services in this cost sheet. And when you select those services, it's automatically going to insert the correct procedure codes. And then for all of the rates that have like a fixed, or all the services that have a fixed rate, those are going to also automatically populate. There will be some alerts that will automatically appear if a plan is over budget. There are two separate costing pages just because of some of the differences in how budgets can be used for supported living level M and B. There is a separate costing sheet for them, and we'll just briefly go over the differences, but they're very similar. Just like the ISP that Danae went over, these slides are set up very similarly. We have slides that have instructions followed by examples in a lot of places. I am going to, for the most part, skip straight to examples, but these are here as a resource for you. And then again, the manuals are going to have detailed instructions as well for all of these cost sheets that we're going to go through today. So this is the first part of the costing page, and up at the top is the header. And so you'll type in the adult's name, their Medicaid ID number, the name of the plan developer, and then where it says service mix or level, that's going to be a drop-down menu, and you can select the service mix and the support level that's on the participant's eligibility letter. And so you'll select that. And then on the right-hand side, the plan start date, and I'm going to try to follow along here with the mouse if you can see that. We have the plan start date and the plan end date. And so once those have been typed in, it's going to automatically calculate the number of months in a plan. So for a full year plan, it's going to have 12 months. And under where it says prorated plan, it will say no. If this is a mid-year plan or a prorated plan, it will have the correct number of months here, and it will indicate that it's a prorated plan. If for some reason, maybe there's a typo in the dates or something like that, you may get an error message that will indicate to you that there does need to be a correction here to get this to fill in properly. Once all of this header information has been entered, that is when the budgets will automatically calculate. And again, they'll be prorated if it's a prorated plan. So it will have the plan development budget, the residential budget, and the discretionary budget. And then the amount remaining in the plan will also automatically calculate once you've got that header filled out. So next we'll talk about how to enter services onto the cost page. And I'm going to go over these instructions and then we'll skip over to the examples. The first column will have a services section where there's a drop-down menu where you can select those services, and it will automatically enter in that procedure code for you. The provider name you'll need to type in, and then the start and end date. This is very similar to how you do that currently. Just make sure that when you're typing in that provider name that you're doing the name that's in Gainwell and on the ISP questionnaire. And then you'll type in the number of units and the frequency, again, very similar to our current cost page. And then the rate will automatically populate for services that have fixed rate. The only caveat here is that while I said that the costing sheet is locked to protect all of the formulas, because we have a few services that are manual rates that have to be manually entered in, there's some areas where we can't lock those formulas in there. And so it is possible that you could possibly delete out a rate or do something like that, but you can always type those in manually. So that's just one thing to watch and make sure that as you are filling out these cost page, double checking those rates and make sure that they are entered correctly. And then the annual costs and the annual units are going to automatically populate. So the first section of the costing page, plan development and service coordination supports. So only plan development and service coordination services are going to be allowable in this section. So they'll be the only services in that drop-down menu. Again, that code will automatically populate. You'll type in the provider name, start and end dates, the number of units and frequency. That rate in this section will automatically populate, and these ones are locked because none of these are variable rates. And then that annual cost and annual units will automatically calculate. So this top example is within budget, and so that's what this will look like. But down here on this bottom example, I have an example for if this was entered in and was to go over budget. And so what will happen is that the amount remaining will highlight in yellow, showing that negative amount. And then this alert down here at the bottom will show up that says services over budget, bring services within assigned budget. Because plan development is not, and service coordination, this is not a service that can exceed budget. It will prompt you to make sure to bring that within the budget. In the residential support section, the only services that will be available are certified family home and supported living services. The residential supports remaining field will automatically populate as well. And so if it's over budget, it's going to do the same thing as that other section. This residential supports remaining is going to highlight yellow, showing that negative amount. And then there's going to be an alert that shows up that says services are over budget, budget modification required, or additional supported living can be requested with discretionary funds. So this alert is to remind plan developers that if it's over budget, if they're choosing to do budget modification because the additional support is needed and it meets those health and safety criteria, that they can do that and to submit that budget modification request. But they can also use their additional discretionary funds. So if they have additional money in their discretionary budget that they're not using, they can absolutely do that. But that's not a requirement. They do not have to use the discretionary funds to purchase the additional supported living first. And then again, these totals will automatically calculate the residential supports budget, will automatically calculate along with that amount remaining. In the discretionary support section, this is going to be similar, where you have the drop down and it will only have the discretionary services in this section that will be available. Those codes will automatically populate for you. You'll type in all of the provider names, start and end dates, units and frequency. The rates, this is a section that we cannot lock the rates in this discretionary services section because we do have some services that do have to have a manual cost entered in. So you'll want to really make sure you're verifying that those rates are correct. And then the annual cost in annual units will automatically calculate. We've got an example down here on the bottom of what this would look like if it is over budget. So in this example, this is over budget, so it highlights yellow, and then there is this red banner down here that will come up that reminds you services are over budget, budget modification required. So you would need to submit a budget modification if this section is over budget. One other thing to note here is that if requesting additional budget dollars for discretionary services, if there are any supplemental supported living services that are being requested, they need to be moved up to the residential. So you can still request additional budget dollars for those, but those residential services would need to be requested in the residential section, and then that budget modification for the discretionary supports would be just for those discretionary services. And then the next section of the cost page is for the health, safety, and employment services. So these are those services that have been designated as health, safety, and employment that don't come out of either that residential discretionary or planning budget component. So only those services will be available in this section. There's no budget for this section, so it will just have a total for all of those services. And when services are entered into the section, if there are any services entered at all in this section, this red banner will come up that says supporting documentation required. And so that's just a reminder to make sure to submit that documentation when you're submitting the plan. And again, we went over a lot of this in the part 1 training, so you can refer that back to that if needed. And then also the manual, once that's available on our external website, chapter 8, we'll go through all of these different services, and it will have detailed information on exactly what documentation needs to be submitted for what service. And then the plan summary, the overall plan total is going to automatically calculate. And then we have a section here for care managers to sign when they're approving the plan. And then we have a section right here on this left-hand side that is to account for the ARP budget and what we need to do with those ARP budgets. So where it says ARP budget, this white box right here, this is where you'll type in that budget from the eligibility notice. And so you'll type in that budget, and then we have 2 different examples. On this costing page, I'm showing the example of what it's going to look like if the plan is below the ARP budget. And then when we get to the addendums, I'll show you what it looks like if it's over budget. So if it's under the ARP budget, this yellow highlighted field is going to show up, and it will say overall plan total is lower than or equal to the ARP budget. And then it will ask, would you like to use your ARP budget instead of submitting a budget modification request for services over your advisory budget? And then this is a drop down where you can pick yes, no, or NA. And then there is a reminder down here at the bottom just to remind you that any services over that advisory budget, including services requested using the ARP budget, must meet those prior authorization criteria in IDAPA that we went over at the beginning of this training. And then over here on the right-hand side, we have a fiscal plan summary, and this has a lot of information, a lot of numbers in here. And these totals, you don't need to know a ton about them. I'm going to briefly explain what they are, but they are going to be used by the department to be able to evaluate the new budget model. And so over here we have, there's an overall plan total, and then there is the residential services authorized total, which is the amount of residential services that have been authorized. We have the discretionary supported living total. So that's any supported living out of that discretionary budget that's been approved. We have the residential services modification. So this would be any amount above that residential budget for for residential services. Then we have a total for discretionary services, and for discretionary services that are within the budget, and then discretionary services that are out of residential budget. This does not apply to anything on the regular cost sheet. This will only apply when we get to the supported living level M and B, and we'll kind of go over that in a minute. We have a section here for the amount of any discretionary services budget modification, and then we have a total for those health, safety, and employment services. So you won't have to calculate any of these. It's not super important that you understand what each one of these totals are, but they are all going to automatically calculate. And again, the purpose for those is just to help us evaluate that new budget model. So let's go over just those differences with the supported living level M and B costing page. The difference that we have to account for and why we have to have this separate costing page is that unused residential budget dollars can be carried over to purchase discretionary services. It is limited to the total value of the discretionary supports for supported living level 3. So this is only supported living level M and B that this applies to. So the costing page for the supported living level M and B is going to automatically populate the discretionary supports budget and the remaining residential available to purchase discretionary. And then both of those can be used for additional discretionary supports. And one thing I failed to mention earlier, but just as a reminder, the examples that we have in here right now are not the current budget amounts, and they're not the current rates that have been approved. We didn't quite have those yet into these examples for these trainings. When we do release those final cost sheets, it will have all accurate budgets and totals. So don't get, especially on this example, don't get too caught up on what these numbers are. They're just in here to show the functionality of the costing page. So in this example, you can see here that this person who requested supported living level M and B is only requesting supported living level 1. So they have a remaining residential budget of $99,000, a little over that, remaining in their residential supports. So from that, we have their, down in the discretionary section, we have their discretionary supports budget. And then we have an additional field here that says remaining residential available to purchase discretionary. This amount is limited to where both the discretionary and the residential together equals that supported living level 3 discretionary budget. So that's the maximum that they can carry over. And then they have both of these to be able to purchase discretionary supports. And so then instead of just saying discretionary, it's the remaining funds available to purchase discretionary supports. So that is the main difference on the M and B costing page. And then in that fiscal summary, that field that said does not apply will apply only on this costing page. I just went through a ton of information. So let's pause and see if there's any questions or hands raised.
Toby has his hand raised. Go ahead, Toby.
Okay, so if they get high supported living right now, then you would do 2 costing sheets? 2 separate costing sheets? With all
I'm sorry, I'm not quite understanding the question.
Well, if they're on high supported living right now, that's M and B in the new system. So would you do 2 costing sheets with a bunch of different numbers from 2 different costing sheets? I don't understand.
Maybe I can take a first stab and then Andrea and Danae can add to it. So you will not move into using the new costing sheets for participants until they migrate into the new budget. So that will happen over the course of a year, and it will be based on their normal recertification date. So they'll get their new budget notice, which will provide them their eligibility and then what level they are assigned to in the new budget. And then that will be the indication that you need to use the new plan forms, the new costing sheets for that individual. So for individuals who maybe need, Okay, go ahead then. Sorry about that, Toby.
That's good. So in the new costing, in the new system, when it starts, whenever they get it, because then they got to, they got to keep the cycle the same.
Yep.
So whenever they recycle into the new system, if they use, well, it's called high supporting living now. It's going to be called M and B when it goes into the new system. It won't be called high anymore. But so do you do 2 costing sheets with 2 different sets of numbers? Submit 2 costing sheets for 1 person to be at each year? That's what I'm.
No.
Okay. I think I am understanding the question now. So first of all, one clarification I want to make. M&B is probably more equivalent to intense than to high supported living, but you'll only do 1 costing sheet. So if they are supported living level M&B, they'll just do the supported living level M&B costing sheet. And it looks almost identical, except for that one difference that I showed. They're almost identical. So you'll just choose. So the supported living level M&B, those will be the only 2 even options for a budget amount or a service mix and level for them to even choose. And then in the other one, those 2 options won't be available. So it'll be really, should be really easy to know which one, because it won't even be an option for the irrelevant costing page. But yeah, you'll just do 1.
So you're still doing 1 costing sheet, depending on the version. You're not doing like 3 or 4.
Right. Yeah, it's just 1.
That's all.
Oops. Sorry, Toby, did I cut you off?
No, that's all.
Okay.
I was just confused. It made it seem like you had to do like 2
Okay.
costing
Thanks.
people if they're high supported living. Well, what used to be called intense and high supported living.
Okay, and we have another question. Any updates on the CMS approval status? We do not have any updates on that status at the present time.
All right. Is that all of the questions that we have?
I do not see any other questions in the chat.
All right. Okay, we still have quite a bit to go through, so I'm going to go ahead and keep moving on. Let's briefly go over implementation plans and status reviews. So implementation plans are not required for providers of specialized medical equipment, home delivered meals, environmental accessibility adaptations, non-medical transportation, PERS, respite care or chore services, community crisis supports, or adult DD service coordination. All other providers are required to develop implementation plans within 14 days of either the receipt of the authorized plan of service or the start date, whichever one of those is later. And then implementation plans are not required to be submitted with plans or with addendums, and they do not require an addendum to be submitted or to be updated. And then for status reviews, all providers who are required to complete implementation plans must also report on the participants' progress towards goals to the plan monitor. Status reviews are submitted to the service coordinator semi-annually and at the annual person-centered planning meeting. And those need to include the status of supports and services to identify progress, maintenance, or the delay of prevention of regression. Semi-annual status reviews must be submitted to the plan monitor for review no later than 15 calendar days from the 6-month date of the plan. Service providers should be prepared to discuss the semi-annual review and information regarding progress made, maintenance, or the delay or prevention of regression of goals at any person-centered planning meeting. And then the annual status reviews must be submitted to the plan monitor no later than 30 calendar days from the end date of the plan. And especially where we're going to have more of these mid-year plans that are prorated, our manual is going to have a lot more detail if there are questions regarding identifying what that 6-month mark looks like. So you can refer to our external manual for any questions on that. So let's go ahead and jump straight into the addendums because we do still have a lot to cover here. The addendum, those must be submitted when there is a change in provider, if there's a change in cost to the plan, if services are being added or removed from the plan. We do have a certified family home alone time change request that should be submitted instead of an addendum if our participant wants to add or increase alone time in a certified family home where they're already residing. And so that's the only change. And then a new mid-year plan will need to be submitted for any changes in the participant's service mix or support level. And we already talked quite a bit about that. And there will be a lot of detail in the manual as well if there's additional questions that come up. And you can also always reach out to your care manager if needed. So new questionnaires must be submitted with the addendum for any services that require a provider implementation plan. So all of those are listed below. That's all of those providers who have questionnaires are the ones who have to do the implementation plans. And so those are the ones that we would need a new questionnaire anytime there's an addendum submitted. The addendum worksheet form is also a Microsoft Excel worksheet. It's set up similar to the costing page. It's got formulas that will automatically calculate the new budget categories and plan totals. It'll automatically calculate a new fiscal plan summary. It has a lot of those same worksheet features where services are selected from a drop-down menu, and then the worksheet will automatically insert the correct procedure codes and rates for all of those at that set rate. It will have alerts to appear if a plan is over budget. And again, there is a separate addendum worksheet to be used for the supported living level M and B plans. Again, just because of how those budgets are a little bit different for that service level and mix. Let's jump straight to the example here of the addendum worksheet. Up at the top in this header, we have where you'll type in the adult's name, their Medicaid ID number, the name of the plan developer, the plan start date and plan end date, and then they'll select that service mix and level, and this will be a drop-down menu. The plan start and end date and that service mix and level should match what is on the original plan costing page. If it's a different service mix and level, it needs to be a new mid-year plan. And then there's a section for the reason for addendum, and this is where you'll type in just the reason or what changes are being made to the plan. And then these sections that are highlighted in red where it says plan development, service coordination, budget, these are going to need to be entered in by the plan developer. So you will type these amounts in. So there's one for the planning budget, the residential budget, and the discretionary budget. And then you'll also need to enter in the previous total for all three of those sections. So this is where you will type those in. One thing to note is that even if you're just making, maybe you're just making a change to plan development, so that's the only thing that's changing, you still need to enter in all of these fields for all sections. Otherwise, the final addendum information and the final plan summaries are not going to be accurate. So you'll automatically type these in. The previous amount remaining is going to automatically calculate here for you. So you do not need to type that in. And then further down at the health, safety, and employment section, there is a section to put that previous health, safety, and employment total. So that needs to be entered in as well for all addendums, even if there's not a change in this section. And then the other section that will need to be typed in by the plan developer is this previous fiscal plan summary. So from the costing page or from the most recent addendum, you'll need to copy in that previous fiscal plan summary. You'll type in all of these fields. So once that is done, you'll type in all of the information for the addendum. A lot of this is going to be very similar to how we do on addendums now, but I am going to go over these in a little bit of detail just to make sure that we've got some clarity on how to do these addendums. So for the service, This is going to be the same. There's going to be that drop-down menu that you can select the service. Only those services that are available in each section will be available. When you select the service, the procedure code will automatically fill in for you. You'll type in the name of the provider as it appears in Gainwell and on that ISP questionnaire if it's relevant. And then for the start date, so for addendums, this is no different than what we're doing now, but I'm just going to go over it. If services are being added or if they're being modified, then the start date is going to be the day that that change is wanting to take effect. And then for services that are being completely discontinued, that start date is going to be left blank. And then for the end date for the service, if it's being added or modified, that end date is going to be the last day of the plan. And then for the end date, or I'm sorry, for services that are being discontinued, that end date is going to be the last day the services are going to be accessed. So then for units, the number of units being added, removed, or modified. So if services are being added or increased, then those units need to be a positive number. And then if they're being removed or if they're being decreased, then the units will be a negative number. And we'll go over a couple of examples here in a minute. The frequency of the number of units being requested. So that's how many, weeks or months, depending on how that's being costed, are remaining in the plan. And that should always be a positive number, even if removing services. So frequency should always be positive. And then that rate, just like the costing page, is automatically going to populate for most services, except for those manually ones. And then just watch, because that is the one place where you could possibly delete a formula in there. So just double check those rates to make sure that they're accurate. And then the annual costs and the annual units will automatically populate. So here are a couple of examples, and just so that we've got plenty of time to make sure to answer questions, I'm not going to go through every single example here, but we'll go over a couple. So looking at this example, changing service coordination, they are just switching service coordination agencies here. So you can see that for the service that was selected from the drop-down menu, that code will automatically populate. You'll type in the provider name. So they're changing from ABC service coordination to EFG service coordination. Since ABC is completely ending, that end date of 8/31/22 would be the last day that they're accessing that the service through that provider. And then the next day, 9/1/2022, that's when the new provider starts service. So that's the day that that change is taking effect. And then 5/31/23, that would be the end date of the plan. For units, we have that -18, so we're taking off the 18 units for the service that's being removed. For the one that's being added, that's a positive number. The frequency, this is a 9-month span here, so our frequency is 9 for both. Even though this one's being removed, that number stays a positive. We have the rate will automatically fill in for you, as will the annual cost and the annual units. And then down here at the bottom, there's 2 fields and they're labeled the same, and those numbers are going to be the same, but it has the amount of change, and then it has the new amount remaining, and then the new total. So in this example up here, there was no change in costs, so there's 0 change. There's still nothing remaining here, and then it has whatever that new total is going to be. On this next example down here in the residential supports, this participant is switching from a supported living level to per diem. And then they're adding supported living supplemental individual units. And so in this section, we have where they're selecting that. We have the end date of this per diem because that's completely ending. Notice those units are negative. and then where they're adding in, it's the start date is that next day, and then the end date of the plan is that end date. They're adding those additional services. All those annual costs and annual units will automatically calculate. And then down here at the bottom, we have the residential supports change. It shows how much that is changing by, and then the new amount remaining and the new residential supports total is showing. So we have some additional examples here. And I'm not going to go over all of these, but they are here for your reference. Again, these slides have been emailed out, and they also will be available on the My Choice Matters website for you, just showing some of the different changes that may happen. But all of these totals are going to automatically calculate to where you'll see the new discretionary supports remaining and the new discretionary supports total. And then for health, safety, and employment services, this is similar. The only difference is the only field you are going to have is the amount of change and then the new total. If a section is over budget, those red banners, just like on the costing page, are going to appear. And I'll go over here in just a minute, the guidance that we're giving on those. We still have those banners there, just as a reminder for plan developers to look at that closely. The amount of plan change is going to automatically calculate, and so will the new overall plan total. And then for the addendum signatures, we have a section here for the participant and their guardian if they have one to sign, and then for the service coordinator to sign as well. And then down here at the bottom, there is a place for the care manager to sign when they are approving the addendum. And then the next section of the addendum worksheet is that fiscal plan summary. And you can see over here on this right-hand side, this is that previous fiscal plan summary that the plan developer is going to be typing in. Over here on the left-hand side, we have a section for entering in the ARP budget information. This is what I was talking about earlier, where I'm going to show you an example of what it will look like if the plan or addendum is over that ARP budget. So in this example, they type in the ARP budget. In this example was $60,000. So since that amount is lower than the new plan total over here, the overall plan exceeds the ARP budget is going to show up and be highlighted red. And then it will ask the question, budget modification request is required for services over the advisory budget. Has a budget modification request been submitted with the plan? And then there is a drop-down menu where you can select yes, no, or NA. And then again, there's this reminder about the prior authorization criteria needing to be met. And then from that information, the new fiscal plan summary is going to appear. This section on the left is just the amount of change to each of those categories. And then this section that's highlighted in red, those are going to be all the new totals. So if you have a plan that has multiple addendums, when you're doing the next addendum, this section highlighted in red is the section that you are going to pull those numbers from, that you'll type into this section on the new addendum. And then just a couple of other additional addendum considerations to go over. So addendums that are over budget or requesting health, safety, or employment services will show the same prompts as the costing page for each section. So budget modifications and supporting documentation will be required for any addendums that are adding or are changing services that are over budget. The budget modifications and supporting documentation will not be required if that section is not being changed or if the only change is a decrease from what was requested previously. And then if a participant is requesting a budget modification for discretionary supports, any previously requested supported living that was requested through the discretionary dollars needs to be moved up into that residential section. And then if they want, they can submit a budget modification for that. But it needs to be moved up into the residential section, and then the discretionary will just have those discretionary services. So that was a ton of information that I just went through. So let's go ahead and pause for questions.
First of all, Toby still has his hand raised. Is that from the previous time, or do you have an additional question, Toby?
No, I keep forgetting to do that hand close thing. I'm sorry.
That's okay. Thank you. Okay, so then there was a question. Do start dates still need to be 14 days out?
For addendums, yes. Yes, we still have the same review timelines for plans and addendums. If there are those extenuating circumstances, that's where you would need to reach out to the care manager.
On this question, we might need to take it back for review. Alina, you were a panelist on the training this morning, so I just want to ask you if this question makes any sense to you, and if not, then we can take it back for response later. Michael K. stated an addendum would be needed to correct errors on the plan, such as incorrect formal or informal goals, and this was confirmed by the panel earlier today in the ResHab provider training. Is this your understanding too?
That is correct. So if after the point that a plan has been approved, there is then a later identification that there has been an error, then it would require an addendum. Now, if there was an event where the plan was still currently under review by the care managers and you identified that there had been some sort of an error, a typo, etc., then it's my understanding, and Andrea and Danae can correct me if I'm wrong, that there would be the ability to make that correction before having to do an addendum if it was still sort of in the process. But that if there was, truly an error, that an addendum just correcting the error would be necessary as per Michael's previous identification. But if there's any other guidance from the panel, I absolutely be more than happy to bring that back for discussion by the core KW team to identify if that is not, an accurate review of what the expectation is.
I think that may need to go back to the team, because I do think maybe there's some confusion or maybe talking about two different things. So that may be something that we need to take back, because I mean, as far as the goals, those are being signed by the provider on those questionnaires. So I think we probably need to take that one back and get some clarification.
Yeah, I agree. There are certain errors that we know definitely would need an addendum, like if it affects that costing or the wrong services were authorized, things that don't typically fall within the addendum process, like incorrect formal or informal goals. I think that's something that we would need to staff and probably come out with a list of things that require an addendum and don't require an addendum.
So we will take that back, clarify that guidance, and make sure that people have revised and updated clear instructions on what to do in those circumstances.
Okay, there's another comment here about being confused between situations that require a mid-year plan or addendum. Danae or Andrea, could you guys speak to that?
Yeah, I can go ahead and, oh, sorry, go ahead.
No, either way. So long story short is if the change in the situation requires you to get a new budget from Liberty, then it's required to be a mid-year plan. But if you're working within their service mix and level and everything fits within that, they're in that same service mix, they don't need to go up a level, their situation hasn't changed, then it's an addendum. But if there is a change in conditions, something has changed and they need to move from a level 2 to a level 3, then that requires us to go over to Liberty, and Liberty is going to reevaluate them, and if they qualify now, they're going to shoot them out a new budget. So, or if there's a service mix, so they are currently residing in supported living and they want to go to certified family home. Those are different service mixes. So that change in the service mix, you're going to have to fill out the form. That'll go to Liberty. Liberty's going to spit out a new budget. So anytime any of those things happen where you're getting a new budget notice, that's going to equal a mid-year plan.
And I was going to say the same thing today, that I think the easiest shorthand is that if a new budget notice comes out, then that would be a reason for a mid-year plan. Otherwise, it can be handled through addendum.
I wanted to ask a clarifying question on that. So if the service mix has to be changed, that's what provokes people to need to go to Liberty for a new budget. Is that correct as well?
Correct. Yeah, a service mix change or a change in condition. So it's like their service mix, meaning they still want the same level, their condition hasn't changed, but their situation, like their living situation, is changing. But the change in condition means that their condition has changed and they're needing more support than they did when they got that assessment. So then they're going to have to go to Liberty to get reassessed to see if their new CISA would now qualify them or change their level and bump them up to what their needed services.
So anytime someone gets a new level or a new service mix, that's when you need to do a mid-year plan. If neither of those two elements are changing, then whatever change needs to occur can be handled through addendum.
That's very clear. Thank you, Elena. Is there a change, increase, or decrease in service mix? If there is a change, increase, or decrease in service mix, does both an addendum and a mid-year plan need to be submitted? Or would there be any circumstance where both an addendum and a mid-year plan need to be submitted?
So it's under review right now. So at some point we have to close out the old plan. So if there's a change that requires a new plan, we're going to have to close out the old plan to start the new plan. So it is under review right now if that's something we're going to do internally, or if we're going to ask service coordinators to submit an addendum to close out the old plan. So that's kind of the situation where you're going to see an addendum and a mid-year plan is if in the circumstance the decision is made that you'd have to close out that old plan. But in general, if it's a change that requires an addendum, it doesn't require a mid-year plan. And if it's a mid-year plan, then it's not an additional addendum. It's just all those new services and changes are being put on the mid-year plan.
Okay, and it sounds like a mid-year plan change is similar to what would have previously been a change in condition.
The differences in that is currently our change in condition process, you submit the change in condition documentation, it goes to Liberty, they spit out a new budget, and then you submit an addendum to change those services to the participant needs. What's changing there is you're going to still fill out that change in condition, you're still going to provide that documentation, it's still going over to Liberty, they're going to reevaluate, and if something has changed and that's approved, you're going to receive a new notice with a new budget. Instead of submitting the addendum to add that new service that new budget now accounts for, that's going to be a mid-year plan.
Okay, one last question, then we're going to get moving because we still have quite a bit of material to get through. Mid-year plans receive a new PD authorization of 12 more hours, right?
Correct.
Yes.
That is per plan. So yes, if there is a new mid-year plan that has to be developed, they can request an additional 12 more hours of plan development.
Okay.
All right, we still have a decent amount to get through, so I'm going to go through the rest of this pretty quickly. But the rest of this, we're just going over a couple of additional types of forms and that type of information that you'll just see here and there. The first thing that we want to go over are the certified alone time change request forms. This has been developed for both traditional and self-direct, so you'll see references to both. So you'll just refer to the traditional portion. I'm going to skip straight to the examples, but those instructions are always there for you. And will be in the manual as well. The header is just like on the plan, where you'll type in their name, Medicaid ID number, and their plan start date. And then there's a section for demographic information for the participant, and then for the guardian if they have one. And then there's a section for the plan developer's information as well, where they will type in that plan developer or service coordinator information. And then the next section on this form is for alone time in a certified family home. The first question asks, has the participant utilized alone time in the past? Yes or no? So if this is marked yes, they need to describe how much and for how long, and if it was discontinued, why that was done. So this says that John currently has 1 hour a day of alone time at home. And then does the participant or guardian want to utilize alone time now? Yes or no? This should be marked a yes. We are looking that this alone time is participant driven, that this is alone time because the participant wants it. And then it should describe the volume or the amount of alone time being requested and where and when that's going to take place. So for this example, John has done well with 1 hour of alone time at home and would like to increase to 2 hours per day with time both at home and in the community. And then this last question just asks you to describe the risks or safety concerns when the participant is alone and identify what measures are in place to minimize that risk, including any backup plans or strategies. And so for this example, we just have John is very trusting of strangers and could be vulnerable to financial exploitation by others. The certified family home will discuss safety skills before community alone time activities, and John will take only enough money into the community to pay for his own activities. So once those 3 questions are answered, there's a section for the participant and their guardian to sign if they have one, a place for the plan developer to sign, and then at the very bottom, this is where the care manager will sign when they are approving the request. And then just this last bit of housekeeping that we have is just to talk about appeals for a minute. We're just going to do a brief overview of appeals. Participants will have the right to appeal all program eligibility determinations, the results of any program assessments like the Vineland or the CISA, any support level assignments, verification review decisions, their assigned budget, the outcome of any budget modification requests, service mix changes, changing conditions, and then any authorizations for services. If a participant disagrees with a decision made by the Department of Health and Welfare, they must request a hearing within 28 days from when that notice was mailed. Requests for appeals must be in writing, and they can be submitted on the BDDS appeals request form that is attached to all notices, or they can also write a letter requesting an appeal. And then participants also do have the right to withdraw those requests for appeal at any time. And further details on submitting appeals are included on all of those notices. So with that, we'll open it up for some final questions. And feel free to raise your hand as well if you'd like to ask your question verbally.
I do not see any hands raised or any additional questions in the chat at this point.
Okay, we'll go ahead and give it another minute or so to see if there's any additional questions that trickle in, and if not, then we'll give you back the last couple of minutes.
Sorry, y'all, that was my phone. There's a question that has come in. Do you have a date yet as to when the new ISP manual and forms will be available?
So I don't believe we have a date on those yet. Some of that is dependent on CMS approval. So we don't have a firm date on that yet, but we will communicate as soon as those are available.
When there are rate increases, will the forms update to the new rates?
Yes, we will need to update those forms when there are new rates. So yes.
And I'm not seeing any more questions or hands raised, so I think we're going to go ahead and give everybody about 3 minutes back in their day, and we appreciate you all coming for the training today.